Ooh! What happened to the screen? Oh no! Aha! There we go. It scared me. Well, that was my favorite scene on Back to the Future. Shades up or shades down, guys? Eyes off, computer off. Hey, I told you I was watching next to your pencil and paper, no slides ahead of time. That's how it's like it to be. 8:30 in the morning. Yeah. All right, good afternoon, everyone. Good afternoon. Now, someone has told me, and this is a rumor that we have a lab exam on Wednesday. Have you guys heard about this? Oh, what? Lab exam? All right, so I want to take a poll. I want to take a vote. Who would like to delay the lab exam until Friday? And don't worry, we're not going to do it. It's always nice to get that little glimmer of hope. But nope, no, it's Wednesday. It's Wednesday. All right, so I'm going to post onto Canvas the details for the lab exam. It's going to be the same format that we've done in the past, right? So the steeplechase, aka station style exam. It's going to be 52 questions. Obviously, I'm going to take that exam score out of 50, so quote 2 rolling bonuses that we usually do in this class. It's going to cover everything that we have covered so far this semester, plus cumulative stuff, okay? So I'm not going to get super duper detailed with the cumulative stuff, but if you see a picture of a humerus, or you see brachial plexus, ooh. Or you see a hand. Oh, right? So that is one thing that we have to be prepared for, is that we're reviewing this material. I know. Okay, so expect that you could see some of those questions on the lab exam, okay? I'll be quite honest with you, I gave you guys a little bit of a break on the written exam that we didn't have any last semester stuff. Like I said, if you read the syllabus, then we can have some cumulative stuff up to 25% of the exam. Okay, so just be prepared. So what we're going to cover today is I want to go over a couple force diagrams of the hip. These pictures look super duper complicated, but if you kind of understand what they're all about, they make life very, very easy. We're also going to get into a little bit of functional anatomy / biomechanics today. This is where you guys say yay. No? So hopefully we can make biomechanics a little easier to understand. Okay. In addition to that, we're going to cover the blood supply of the hip. We're also going to, if we can get to it, femoral triangle as well. After today, we're going to move on to the thigh. The thigh is fairly straightforward. Okay, there's not a whole lot going on in the thigh. It's kind of like the humerus. We're kind of like, yep, there's the stuff, we'll move on. When we get out into the knee, we're going to cover even more with the knee, but realize that we are going to consistently throughout the rest of the semester come back to the hip, because what we're going to find out is coxivera, coxivalga, anteversion, retroversion, all of these terms that we talked about will have implications at the knee. They will have implications at the tibia and the fibula. They will have implications at your ankle. They'll have implications at your feet. They'll have implications in your toes because of that weight-bearing component. So please be aware of that we're going to continually add on information, right? So we're going to start stacking information on top of other information for the rest of the semester. So in Newman's kinesiology textbook, and I am more than willing to post this on Canvas for you guys, Newman, in my opinion, has done a very good job at providing force diagrams of all the little different muscles we have that attach into my femur and make my femoral acetabular joint move. What I want you to realize is, and I answered a question earlier about this, understand all the same muscle principles we've talked about throughout this semester and last semester still apply. So if you guys remember, we talked about muscle striation and why muscle striation is important. So what I want you to do is I want you to think about not only where that muscle attaches, right? Yes, it is important to remember the origins and the insertions and all of that with detail. But it's also very important to understand conceptually how that muscle acts, how that muscle moves. And the example I'm going to give is gluteus maximus, right? So what are the actions of gluteus maximus? Extension or extension of a flexed hip? Okay, big difference. Okay, what's the other actions? Lateral rotation and abduction. Okay, why are those the actions? Muscle striation, right? Muscles are not the smartest thing. Okay, I mean, there's a reason that we sometimes refer to as a muscle head as someone that lacks some cognitive ability, right? Muscles are not the brightest bulbs in the box. When I stimulate a muscle, that muscle will do its one job. That muscle's job is to bring the insertion point closer to the origin point. That's it. That's all it does. Based on the fiber striation of that muscle, that will dictate what motions happen at that joint. So how would you describe the muscle striation patterns of gluteus maximus? Are they in one plane or are they in multiple planes? How many planes? I'm going 3, right? They're in 3 planes. Would you say that the striation pattern of gluteus maximus is oblique? Is it straight up and down like rectus femoris is? Right? Is it like transverse abdominis? No, it's on an oblique plane. It's going to cross multiple planes. If a muscle crosses multiple planes, it's going to have multiple actions. This is why gluteus maximus does so many things. when you guys take exercise prescription in the summer, and when you guys take exercise physiology in the summer, this is really going to start to click. Right now, it's just a bunch of data points. Right now, it's like, okay, got it, memorize it, going to move on. But you have to understand how charts like what's up on the screen really are going to affect certain motions. So getting into this picture, what the blue dot represents is the center or the axis of rotation, right? Pretty easy. What I want you to start thinking about and considering is where each of those muscles are located relative to the axis. Okay, so if my reference frame, my reference point is the axis, where's gluteus medius posterior fibers? Anterior to the axis or the posterior to the axis? Posterior, right? But where's gluteus medius anterior fibers? Anterior to the axis, kind of, sort of, right? A little bit. This is why when we look at the different fibers of gluteus medius, we're not just going to get only abduction, right? Remember, those anterior fibers do something, those posterior fibers do something. This becomes a very, very big concept, especially when we're dealing with surgical populations, right? What muscle they're going to cut when they do a lateral approach and do an ORIF on a patient? Gluteus med, gluteus mid, right? Are they going to cut the whole thing or just part of it? It kind of depends. It depends on the surgeon a little bit. Let's say they only cut the anterior fibers. Are those anterior fibers going to work right after surgery? Heck no. So what would you expect to see when I ask my patient to perform hip abduction? It's not going to be pure abduction, is it? I'm probably going to have a little bit of abduction and external rotation. Why am I going to have external rotation? Because the posterior fibers are posterior to the axis of rotation. Therefore, when I contract those muscle fibers, because of their orientation, they're going to pull the femur into external rotation. Okay, so you have to understand how these muscle fibers are all put together. Now, under normal circumstances, like we said, when I have gluteus medius and it contracts, I have fibers going to the anterior direction, and I have fibers going to the posterior direction. But they're both on the oblique plane. As we have seen, when I have something on a diagonal, that means that I have a vertical component, a Y direction component, and I have an X direction component, right? Uh-oh, this is sounding a lot like biomechanics, isn't it? So if I have negative 1Y and positive 1Y, what's the net force? Zero, right? But if I have positive 1x and positive 1x, what's the net force? 2. And that's exactly what we see with the diagonal. Okay, so we're going to see this over and over and over again. We're going to see this in glute medius. We're going to see this in our hamstrings, right? Because when you start looking at your hamstrings, especially their action at the knee, you're going to see that biceps femoris and semimembranosus, semitendinosus do two different things. They don't just flex the knee. But you have to understand how these muscles work in conjunction with one another, how they work in synergy. So charts like this are going to become very, very important, especially when we start dealing with selective muscle neglect, selective muscle rupture or trauma. Okay, so the reason I'm belaboring this point so much is because there will be exam questions. Hey, this patient had X muscle cut. You asked as a physical therapist for this patient to perform this motion. You saw this. What's the most likely reason? Okay, so there's going to be a lot of exam questions like that. And you're going to have to understand much different than we saw in the upper extremity. In the upper extremity, it was kind of point and shoot. right? And I understand those exams were difficult, but we're going to start adding on this layer of synergy because as a physical therapist, you're going to have to understand how those muscles work together. So the other chart is this one here. I'm going to get rid of this is obviously looking at kind of an AP or a PA view of the hip. Obviously, we still have our axis of rotation right here in the middle. And we can see a lot of different things here. Okay, and a couple I want to point out here are going to be piriformis. Okay, and we talked about piriformis. What are the attachments of piriformis? What's the origin? Anterior sacrum. What is the insertion of piriformis? Greater trochanter of the femur. What is the action of piriformis? External rotation of a neutral hip, but when I bring that hip up into 90 degrees of flexion, what happens? Abduction. Why? Magic? Muscle fiber striation? Kind of. Because the striation doesn't change. The stretch? Tell me about that. What?
How you have it stretched.
How you have it stretched? Well, you can't give me the definition of a word with the same word. That's like asking someone what is water. Well, it's like water. But okay, so I'm gonna assume you're gonna make this statement. So when I am in anatomic neutral position, my greater trochanter is oriented in the superior aspect, superior portion of my femur, right? It's up here. When I flex my hip, where does my greater trochanter go? It slides to the posterior portion, right? Remember, muscles are dumb. When I recruit that muscle, when I fire that muscle, it's going to bring the insertion closer to the origin. Whether that is external rotation, okay, because that's what that piriformis is doing. That piriformis is simply moving my greater trochanter closer to my sacrum. Or slide back, bring greater trochanter closer to sacrum. Okay, this becomes a big issue because what you're going to see, you guys are going to be asked this over the summer and asked this next year in MSK. How do you stretch the piriformis? Hip flexion, external rotation. But we just said that piriformis externally rotates. What? Like we have to actually take a pigeon and stretch it? I don't have any pigeons. I don't know. So okay. So my bias is going to come out here a little bit. I see it. My bias is going to come out here a little bit. I'm a brand new therapist. I have no idea. First day in the clinic, and I see in the chart pigeon stretch. Right? Because I'll be quite honest with you, I do not know what that is. And to tell you a quick story, this happened to me, and this is why I have such a bias against these names. I get into the clinic, brand new therapist. I write down on the chart, skull crushers. Cool, right? I know what a skull crusher is. We're gonna do some tricep curls, we're gonna do some of these, right? PTA walks in, sits the patient down, puts both hands on the side of the patient's head, and starts squeezing. Because that's a skull crusher, right? That's the problem. Okay, and I'm not picking on you for that statement, but that's kind of the issue. Yes?
You would do for the stretching of the flexion deduction, right?
You could definitely do a deduction. Now here's the issue, right? Now, and this is where you will feel a stretch somewhere in the back doing this kind of figure 4 with end range flexion. You can move that hip, you can move that femur into a bunch of flexion And eventually what you're going to do is you're going to move the insertion away from the origin, right? Because remember, as more I flex that hip, the farther I'm moving that greater trochanter away, farther's going down, right? So eventually you're going to hit a point where you're going to feel a stretch. So can you stretch piriformis doing that? Absolutely. Can you stretch it a bunch of other ways? Absolutely, right? But you have to understand how these mechanics are going to work. So understand charts like this. Understand how these muscles are going to start acting with other muscles, okay? Because that's going to be a concept not only through this course, as you take other courses throughout this program, you are really, really, really going to hit. Like this is going to become a huge one in gait and movement analysis next year. All right, femoral triangle, yeah.
So to stretch the piriformis, you flex the hip at 90 and then you hip 80.
You can. You can. Or you can just flex the hip beyond what that person probably should do, and it'll eventually stretch it. Or you can internally rotate it, right? Because I can internally rotate, and you guys want to try this, it's fine. I can just start internally rotating, and for my retrograde hips, this is not fun. And I'm like, okay, I'm feeling a stretch in my piriformis, right? Because what does the piriformis do with a neutral hip? They externally rotate. What have we learned about stretching a muscle? So the opposite of its action. Okay? So to your point, I can take a flexed hip, and I can adduct, and I can feel a stretch in piriformis. Okay? The old school traditional way is this figure 4 stretch. Patient reaches through, flexes their hip maximum. Yeah, you'll get to a point where you're going to feel stretch in piriformis. By ours, you're going to feel stretch in a lot of things too.
So with that figure 4 stretch, you're externally rotating, but the only reason why it's stretching is because of the extreme flexion.
Exactly right. Exactly right. So, because if you really think about it, I can stretch a lot of different muscles in a lot of different ways, right? So, let's think about trapezius, for example. Okay, I'm going to take you back to like day 2 of anatomy, right? Wow, I forgot I had a trapezius. We've covered so much since then. So, what I can do, what does trapezius do? This number, right? So how can I stretch trapezius? Right, I can do opposite contralateral side bending. Would I not also be able to pull down and do distraction? Right? Could I not just pull down or push down on the patient's shoulder and get a stretch? Like, I'm going to stretch that trapezius then because I'm super duper tight. Okay, makes sense? So there's going to be a best way. There's also going to be a lot of other ways you can get the same job done. Does that make sense? Okay. So it's a big concept. When you guys take exercise prescription in the summer, that's going to be a huge, huge concept. All right, so femoral triangle. Lots of fun. Lots of fun. So remember what we talked about with triangles and these anatomic spaces, right? So the first thing you have to understand with any of these anatomic spaces is location, right? Borders and contents. This one is super duper important, not just in the context of this course, but for patient safety. Whatever you do, please do not lacerate the femoral artery. Promise me, you're not going to lacerate the femoral artery. That's a bad day in the office. So for the femoral triangle, the location is going to be essentially anterior hip, anterior femur, okay? We're going to get into the borders and the contents here. So essentially what I have is I'm going to have as my superior edge, superior border, is going to be the inguinal ligament. Now remember how important that inguinal ligament is, because not only is it going to form or help form that inguinal canal that we went over a couple weeks ago, but it's also going to be one of my huge lines of demarcation that makes my arteries change names, right? We talked about that. So what we're going to see with the inguinal ligament is that my vessels are going to change names from common iliac, external iliac is more accurate, down to femoral artery. Another big border I'm going to have here is going to be that big, what we call hacky sac muscle, which is going to be sartorius. Another large border, and this is going to be the medial border, is going to be adductor longus. Those are going to be the superior, lateral, and medial borders. So superior border, inguinal ligament, lateral border, sartorius, medial border, adductor longus. What we're going to add in, and this is where it becomes super duper important, is we're going to add in two muscles that are going to make up the floor of the inguinal, the femoral triangle. So the first muscle that's going to provide a floor, and we're going to draw this in kind of like this. This is going to be pectineus. The other muscle that's going to provide the floor on the lateral side is essentially going to be this iliopsoas muscle. So femoral triangle, superior border is inguinal ligament, medial border is adductor longus, lateral border is sartorius, lateral floor iliopsoas, medial floor pectineus. Now in terms of the contents, what we are going to see here is we are going to see a nerve, artery, and vein. Now, you guys have seen this in cadaver lab, that nerve, artery, and vein are contained in a neurovascular bundle, and a pretty thick one, right? I know a few of you have asked me to come over, it's like, well, is that femoral artery, or what is that? And you just point to this big mass of stuff. So understand that the contents of the femoral triangle are going to be in a neurovascular bundle. They're going to be in a large bound structure. What we're going to see here is we're going to see in yellow, we're going to have the femoral nerve. In red, we're going to have the femoral artery. and in blue, we're going to see the femoral vein. Now, the mnemonics that were taught to me when I was in PT school, these are a little shortcut to try to remember some of the stuff, is one of two different things. One is navel. All right, so where's your umbilicus? Where's your navel? It's in the middle. Right, so if we work from lateral to medial, nerve, artery, vein, working from lateral to medial. The other one is van, and we just kind of think the van goes out. Vein is most medial, arteries in the middle, nerve is on the lateral side. Now, outside of memorizing this for test questions and things, this is very, very important. How many of you are considering becoming dry needle certified? Okay. How many of you that are considering to be dry needle certified have inserting a needle into somebody? Okay. All right, kind of goes together. All right, exactly. We'll talk after class. So, I am dry needle certified. When I got dry needle certified, we talked about in that course needling iliopsoas, needling pectineus. I personally have had my iliopsoas needled, and I've personally had my pectineus needled. Now, the question is, when you're investigating where to insert the needle, knowing how the anatomy is laid out is very important. So what do you think is a good way to determine where the femoral artery is in that triangle? Because remember, I don't want to slash open that femoral artery. Yeah, palpate the pulse. Exactly. My femoral pulse is a really, really good pulse. So that's exactly how we were taught in that course to needle iliopsoas and needle pectineus, right? If I take my two fingers and put it right on top of the femoral pulse, if I go lateral, I'm going to needle iliopsoas. If I go medial, I'm going to needle pectineus. Make sense? Makes sense. I will tell you that I've had iliopsoas needled all the way down to the point where they were tapping on my iliac fossa. That one was not bad. The thumb, oh, yeah. Medial aspect of the foot, oh, that one hurt. Face, not that bad. Yeah, I've had lateral pterygoid and I've had all that needled. Yep. Actually, there's a picture. There's a picture of me with needles right on either side of my zygomatic arch. I'll see if I can look it up for you guys. I think I still have it on my phone. So understanding, and this is why I think it's very important to cover blood supply. I think this is why it's very important to cover these anatomic structures and these triangles and quadrangular spaces and all the other stuff we've covered, is because there's a good portion of you that are planning to put needles in people. Understand, every time you put a needle in somebody, unless you're doing it with the guidance of ultrasound, it will be blind. So I'm not trying to scare you away from putting needles in people, but what I am asking you to do is be very, very good anatomists, right? If you're going to be dry needle certified, you better understand 3D anatomy really, really well. Okay, so understand how structures like this are made. Any questions on the femoral triangle? Yes?
Is only the artery changing once it goes into inguinal ligament?
No, the vein will change names as well because it comes like a common iliac vein. But the femoral artery stays, I'm sorry, excuse me, femoral nerve stays femoral nerve. Right, because the femoral nerve comes straight out of lumbar plexus. Yeah.
For navel, I don't, NAV is nerve artery big, but E and L stand for.
It's lymphatics.
Okay.
Yep, so there's a large chain of lymphatics in there. So we'll get into this next year when you guys have med screening. You're going to start palpating and talking about palpating lymphatics because that's a really good sign if someone has cancer. All right, any other questions on femoral triangle? Lots of fun, right? You guys look like you just took like an MSK exam or something. I will admit, my ideal teaching time is not right after an exam, because you guys are usually, as we say, a little toasted. Who feels toasted? Okay. I'll tell you what, let's do this. Let's go ahead, let's take 5 minutes, refresh the batteries a little bit, get up, get the blood pumping a little bit, do some jumping jacks. I used to call it blood clot prevention. And then we are going to tackle this diagram. Yes. Number 2. If you think about where I would say that there is a anterior posterior change. So I have here. Exactly. Right. So the fibers. So when we looked at the two pictures, we don't get the whole. So they look at this. Okay. So that's correct. So there's these fibers also run that side. Right. So if you look at Gluteus Maximus, this is what that it comes that's where that first goes. So does it cross the anatomic third plane? No. But it goes from more posterior to less posterior. Makes sense?
Oh, you're not.
We're not having a yeah, but yeah, we're talking about
the other way, just like waving.
Like, there might be a few factors that overlap. The activity is kind of does this make moving motion? Yep, no worries, no worries. All right, guys, let's get rolling again. Okay, so here's what we're going to do. We're going to do a little cross-pollination. All right, I'm going to bring back undergrad biology a little bit. A little cross-pollination between curriculum. All right, so what we have up on the board, I would argue, is a big old nasty force diagram. Agreed? That's a big old nasty force diagram. And I would argue that it's a big old nasty force diagram of the body part that we are covering right now. Right? Agreed. So here's what we're going to do. Let me ask you guys this, okay? So in acute care, more cross-pollination. Wow, look at that. Man. So we are training a patient to use a single point cane. Which hand does the single point cane go in? Your options are ipsilateral, contralateral, both, neither. Contralateral. Just kick it down the road, right? I mean, you know, let's be perfectly honest, right? I make it. Who's seen the patient that comes in? I use the cane. They're just carrying it. That would be a neither, right? So they just kind of throw it over their shoulder. It's like, it was bequeathed to me from my grandfather, and I can't part with it, that sort of thing, right? But yes, I use a cane. I've seen that. I've seen a variety of canes. Let's put it that way. So contralateral was the prevailing answer. That answer is correct. Why?
It replaces the stance leg.
It replaces the stance leg. Okay, so provides extra support. I'm going to argue that person could sit and have extra support. I'm going to argue that they could be like in a halter sling for the rest of their life and have extra support. Okay, and this is where we have to be very careful, and I'm not trying to make fun of you guys too much, a little bit, not too much. But this is why we need to be very careful with our language. Okay, so here's what's going to happen. Miss McGillicuddy is going to come in your clinic. Miss McGillicuddy just had a total hip done on the right side. Miss McGillicuddy has the cane on the right side. You are on your first day of your first clinical. Green as grass. You get to tell Mrs. McGillicuddy, ma'am, I'm very sorry, but you're wrong. How do you think that conversation is going to go? Not good. That's exactly right. Look here, greenhorn. My grandkids are older than you, right? It's going to be something like that. Or they're going to say, but it feels better on this side. Or think about this one. I'm right-handed. I'm right-hand dominant. So you need to convince that person why they need to change their habits. That's a very hard sell. That's a very hard conversation to have because they've already adopted that habit. So what you have to understand is you have to understand how the biomechanics. Yes, absolutely, absolutely.
It was so before you had this hip operation, you walk like this. Or you walk like this. Your opposite hand and your opposite leg are always moving at the same time. Isn't it important then that you maintain that standard of walking? That was always just the easiest thing for me to say. Oh, so you walk like Frankenstein? No, you didn't walk like Frankenstein. You did this. This is an easy way to describe it.
I will see your reciprocal hand motion. I will raise you an even simpler argument. Nope. Don't you want to take weight off of that leg? Don't you want to take weight off of that leg? Let's think about this, right? So if this is my cane, and I'm using my cane, where am I going to lean to put weight on the cane? Didn't he just have surgery on that hip? No. Well, let's just try this. Look, we just took weight off of that hip. Oh. And then we practice, okay? So not to try to one-up you, but I go super simple. So, and one of my old clinic directors, that's what he used to do. 99 out of 100 times, it worked like a charm. Now, don't get me wrong.
Now, all you have to do is tell them. Now you're splitting your weight. Half on your foot, half on your cane.
And that's what we're going to get into. Thank you for the segue. So what we have to think about is this. Okay, let's think back to force equations. What does the equal sign mean? Balance. What's happening on the right side is happening on the left side. I have a static system. Okay? What I want you to consider in terms of biomechanics is that the equal sign is essentially going to be the axis of rotation. Okay? So when we see that equal sign, that means it's the axis of rotation. So what I have with these diagrams is essentially this. I have body weight from my center of mass times the distance to my equal sign happening on one side. Easy as pie. What's that? Yeah, that's all it is a moment arm. That's exactly right. If I want to balance that, because I would argue if we look at this diagram, my body weight is medial to the axis of rotation. Cool? On the lateral side, I have hip abductor force times a different distance to the axis of rotation. And this is what we need to think about when we are prescribing our devices, when we are prescribing and educating our patients on how to use that device. What I am trying to do is I'm trying to, quote, offload the lateral side. What does that mean? I want less force coming out of my hip abductors. I can't change the distance, right? I can't take their femoral neck and smash it together and create less distance, right? But what I can do is I can change how much force it takes to balance that equation. How I do that is I add another force on the medial side. Or if we go super duper medial, the contralateral side. So body weight times distance 1 plus single point cane will equal hip abductive force times D2. Because think about what we would do if we added that single point cane to the lateral side of the equation. Right? What we would essentially do is we would create an imbalance. And this is why you see folks, because let's think about this. This is where some compensation comes in too. If I put the single point cane on the lateral side, aka the ipsilateral side, I've added that force to that side of the equation. I will need to do something to balance the equation. This is where you see compensatory patterns happening, because I can change my distance. What I'm going to do to change the distance, if this is my cane on the ipsilateral side, I'm going to lean over, because I just changed the distance from the center of mass to the axis of rotation. Okay, very similar concept we talked about with Trendelenburg gait. So you have to understand how these equations work, because as difficult as they may seem, because it involves a lot of math and a little bit of trig, they're actually quite simple. Okay? Any questions on that? Yes? PHRF. Where are you seeing that? That's essentially ground reaction force. What that exactly stands for, you got me, but that's essentially ground reaction force. All right, so let's do another example here. All right, so we can change a lot of these variables. So here's your example. We have a patient. They're going to go into the Golden Corral. They go into the Golden Corral and they weigh this. Now, I'm telling you, I'm the type of guy, I go in the Golden Corral, they're losing money on me that day, right? I'm going to get my money's worth, and yours and yours and yours. So I walk out of the Golden Corral and I weigh this. I understand that is an extreme example. Now, truth be told, I've never come out of the Golden Corral weighing that or having that drastic of a change in my weight. But what I want you guys to think about is how that will affect this equation. So if my body weight goes up, how do I balance that diagram? How do I balance that equation? What also needs to go up on the other side? Hip abductor force, doesn't it? Okay. So we see this a lot. And where this becomes a big issue is, like we talked about, if I cannot produce the appropriate force of my hip abductors in this equation, then I'm going to change the distance from center of mass to the axis, right? And we see this a lot. Sometimes it's not just that glute med is weak. Sometimes it's that glute med is not strong enough for the system. Okay, so this is where you need to have that kind of holistic view of this. Because if body weight goes up, hip abductor force also needs to go up. Now, if hip abductor force does not go up, then I'm going to change D2, change the distance. What sorts of problems do you think that D2 and changing that would cause? What's that? Not necessarily laxity, okay? Because here's the other thing. Here's what I want you to consider. Body weight goes what direction? Down. The normal force of my femur goes what direction? Up. Right, so ground reaction force, normal force goes up, body weight goes down. If I have more body weight, that means I have more normal force. That's where these circles come in. Okay, so if I have more body weight going down, I'm going to have more normal force going up. In a static system, I'm going to have compression at my femoral acetabular joint, right? My joint will not have the same space that it had before. In addition to that, I'm going to compress the femoral acetabular joint, but I'm also, as I move, going to create what type of force? What's this force? Friction and or shear. Okay. Now, as I shear into the acetabulum, what sort of structures am I going to shear off? Labrum, that big old piece of cartilage is in there, right? That lunar surface. Remember that? Where's that lunar surface located? In what aspect of the acetabulum? Superior, right? So who has heard the term bone on bone? What does bone on bone mean? It means bones on bone, right? It says what it is what it says. The question is, why is it happening? It's happening because of this equation. This equation, because it's been out of balance, has caused compression and shear forces at the femoral acetabular joint. The body doesn't like that. Now, bone, as it starts to break down, will start to rebuild. Okay, who here has a callus? Right, I got calluses, right? What is a callus? It's extra skin piled onto skin as a response to stress, okay? When bone gets that sort of stress placed upon it, it's going to break down and it's going to repair. It's going to repair with more bone. Do you guys know what that term is when bone repairs with more bone in an inoptimal format? Who's heard the term osteophyte? That's an osteophyte, right? So let's say that this is my nice healthy femoral head. As it starts breaking down, it starts getting all these little craggy little things on it, right? If you look at an x-ray, they almost look like little mountains and little pivots and all sorts of stuff. Sometimes they can be sharp. And let's think about it. What is a sharp surface going to do to that already existing labrum and cartilage in the femoral acetabular joint? Acetabular. It's going to start slicing it, right? It's going to increase friction, increase shear. So we have, unfortunately, a very bad series of events happening. So this is why you see folks go downhill so fast when they have these diagnoses, right? This is why I see a person in 2019 with stage 1 degenerative joint disease, and 3 years later they have stage 4. Because once this process gets going, the joint really starts to degrade fast. So early intervention is the key here, right? This is where we need to be very proactive with our patients. That if we have that patient coming in and they have a diagnosis of arthritis and they're having some problems, get them in fast, okay? Because you can slow that process down and they don't have nearly the problems. All right, any questions about that? Okay.
So after osteophyte, the bone becomes sharp.
It has little sharp little outcroppings. All right, so last thing we're going to cover today before we get into the thigh on Wednesday. So yes, we are having a lecture on Wednesday. Yay. You guys sound thrilled. Absolutely, absolutely thrilled. I will admit, this is that point in the semester where it's like, all right, okay, turn the fire hose off. Okay, we're good, we get it. But spring break's next week. There we go. There's a yay. What's that? Well, it's a week. Oh, yes, you do have 5 tests when you come back, but you have time to study for those tests.
Not spring break, spring study.
Oh, hold on a second. Is it a break? Yes. Is it in spring? Yes, a spring break.
It's a spring break in the
The positivity that's exuding is just, it's inspiring. I think that's the word I'm looking for. It is, yes, it is inspiring. So what we have to understand is a couple things here. When it comes to the femoral artery, remember that the femoral artery is a continuation, essentially the external iliac artery, all right? So we got common, iliac, that's going to branch into internal iliac. We kind of covered that. Then we also have external iliac. And then external iliac is going to become femoral artery. And what we're going to see is that the femoral artery is going to continue on, and it's going to end up being called something called the popliteal artery. We're going to get into this on Wednesday, maybe next Monday, or well, the following Monday. Once the femoral artery passes through something called the adductor hiatus, it's going to change names to the popliteal artery. So be careful, be very, very careful on things like lab exams on what you name these different arteries. Okay, so if I saw an artery that was tagged before entering the adductor hiatus, that's going to be the femoral artery. If it's tagged after it's passed through the adductor hiatus, it's going to pass through the posterior aspect of the knee, that's going to be the popliteal artery. Remember, these arteries are simply named based on where they are. Okay? What we're going to see is that this popliteal artery is going to have more and more branches because eventually it's going to make its way all the way down to the foot. My femoral artery is going to throw off a really, really big branch. And this really big branch is important because this big branch is going to end up supplying all the blood to my hip. And it's going to throw off a branch called the Femoral Profunda Artery. Now, you may see in some literature, this is called the deep artery of the thigh, the deep artery of the hip, the deep artery of something. I think deep artery of the thigh is the other common nomenclature. We're going to stick with the Latin, just because we've done nothing but Latin so far, except for a little bit of Greek. And so the femoral profunda artery says what it is, and it is what it says, right? It's going to be that deep artery in the thigh region. The femoral profunda artery, in terms of hip vasculature, is going to be where all the action is. Okay, because what we're going to see is that the femoral profunda artery is going to provide all the blood supply. And it's going to actually look a lot like the blood supply around the head of the humerus, if you guys remember that. Remember we talked about the anterior and the posterior circumflex arteries, right? We're going to see a very, very similar setup, but they're going to be named something just a little different. Again, didn't hear yet. It's okay, guys. I'm trying to make this as entertaining as possible, and I'm failing miserably. Thanks for saying, no, you're not. Wow, I'll tell you, confidence right now, woo, through the roof. Through the roof, man. That's okay, I'll cry myself to sleep tonight. What was that?
You gotta keep me humble.
Got me humble? Oh, you're keeping me.
Yeah.
Woo! So are you insinuating that I lack humility? As I walk closer slowly. Oh. So my femoral profunda artery is going to provide the vast majority of blood flow to my hip. Now, the reason I say vast majority of blood flow is because we are going to see some anastomosis. Yeah. So I'm going to see some anastomosis, right? And we know why we have anastomosis in the human body, because if I lose blood supply, either via laceration and or occlusion, I still have the ability, although it's not ideal, to keep that tissue alive. So the femoral profunda artery, if we continue on that last picture, I'm going to draw a little schematic here, and then I'm going to draw in on the hip where all this goes. Okay, so my femoral profunda artery is going to branch out, and it's going to have a lateral circumflex femoral artery. And if it has a lateral one, probably would have guessed it, it's going to have a medial one. What we're going to see is the medial circumflex femoral is going to be responsible for getting, aka supplying, the posterior aspect of the femur. Lateral femoral circumflex is going to be responsible for supplying the anterior aspect. This is where life gets a little easier when it comes to these femoral arteries and these circumflex arteries. Each of these circumflex femoral arteries is going to have 3 branches. Those branches are going to have the exact same names. Okay? So what we're going to see is we're going to see an artery that goes up. So we're going to have an ascending. We're going to have a descending. And we're going to have a transverse. The lateral femoral circumflex is going to have that. It's going to have an ascending branch, a descending branch, and a transverse branch. The medial circumflex femoral artery is going to have the exact same thing. It's going to have an ascending branch, a descending branch, and a transverse branch. So when it comes to quote unquote memorizing a lot of this material, you should see a pattern here, right? So when I'm dealing with the femoral profunda artery, it's going to throw off 2 branches, lateral and medial femoral circumflex or circumflex femoral. Each of those circumflex femoral arteries are going to have 3 branches, an ascending branch, a descending branch, and a transverse branch. What we're going to see is a couple different anastomotic patterns here, okay? So what we're going to see is that the ascending branch is actually going to anastomose, from the medial femoral circumflex.
Is that an arrow?
I'm going to erase that one. Is that cool? This is going to anastomose with the superior gluteal artery. What we're also going to see, and I'm going to draw a little dotted line in here, is that the transverse branches are going to wrap around and they're going to anastomose. Right? And we kind of saw this in the humerus, if you guys remember last semester. Right, so you guys remember the anterior and the posterior humeral circumflex or circumflex humeral arteries. Those arteries anastomosed with each other, right? So this kind of wrapped around, met in the middle, so to speak. The only difference here, it's the same type of setup, they're just called a little bit something different. The reason is all because of these medial and lateral circumflex femoral arteries. If we think about it, the femoral profunda artery is coming off of the femoral artery. We didn't really have that sort of branching in humans. But what we have is the medial and the lateral femoral circumflex arteries essentially have the same setup. The medial one just comes off a little bit more medial than the lateral one. So in other words, if I have the femoral profunda artery, and let's say this is my femoral profunda, and over here's medial, and over here's lateral. essentially what happens is one comes around and wraps, and the other one comes off a little more medial and wraps. And that's kind of what they do. The only reason that the medial is called medial is because it branches off the medial side. The only reason that the lateral one is called lateral is because it branches off the lateral side of the femoral profunda artery. That's it. Yes?
So the ascending branch of the lateral circumflex, that does not anastomose with the superior gluteal?
It does not. Superior gluteal is going to be, remember, in the posterior aspect. Yep. Good question. Very good question, though. Yeah. So off the medial circumflex femoral, the ascending branch is going to anastomose with the superior gluteal artery. Okay. All right. Any questions on what's up on the screen? Everybody good? Everybody fried? All right. We're going to do one more thing. We're going to draw this out on a femur, and then that's all we're going to do for the rest of the day. Yeah, what's up? You think you have a question? Would you like me to get back to you when you do have a question?
No.
Okay, okay.
Maybe I might just be like everything going on up here. So it comes off of the Profunda and the circumflexes, they're coming around in the anastomosity, and then the transverse are coming off and going down in the anastomosity, or is that?
So where, okay, so, and that's a very good question. So lateral circumflex and medial circumflex, okay, they're only about this big. Okay, they're tiny little. If I had to rename them, I would call them trunks. Because what is trunk? Trunk means it's going to have a whole bunch of branches. I would call them trunks. But the original anatomists did not call them trunks. They called them circumflex arteries. What happens is that the lateral circumflex and the medial circumflex come right off femoral profunda, and then they immediately shoot these branches.
Okay, so the transverse is wrapped around.
The transverse is what's wrapping around. Okay, so let me draw it out. Is everyone okay if I erase this? Anyone not okay? Okay. Kayla, I think that's a great question. I really think that's a great question. All right, so let's get rid of all this stuff. Okay, so, okay, here comes my femoral profunda. Okay, off of that femoral profunda, and we remember that the femoral profunda is a branch off the femoral artery. I'm going to have a lateral femoral circumflex and I'm going to have a medial femoral circumflex. And they essentially come off right about the same distance down the femoral profunda. So here's what happens. Okay, so let's draw in the lateral first here. So lateral comes through. And it's going to give off an ascending branch and it's going to give off a descending branch. After it gives off those branches, then this becomes the transverse branch. Just a continuation. Okay? Same thing's going to happen on the medial side. So I'm going to have this medial femoral circumflex artery coming through. It's going to give off an ascending branch, and it's going to give off a descending branch, and when it continues on, it's going to continue on as a transverse branch. Does that make better sense? Those transverse branches are going to be what then continues around to anastomosis forma. Okay? Remember that my medial circumflex femoral or medial femoral circumflex is going to supply the posterior aspect. Okay? Lateral femoral circumflex is going to supply the anterior aspect. So I essentially have kind of this trident sort of structure on the anterior side of my femur and the posterior side of my femur. Okay? It's a little different setup than we saw in the humerus, but not that much different. All right? Does that make sense? Any other questions on that?
And the I think you said it, but they just like wrap around.
Transverse are going to wrap around, and they're going to anastomose.
And then the profunda just keeps going down.
The profunda keeps going down, and then what the profunda is going to supply is it's going to give off. And you guys may have seen this in lab. If you haven't, you probably will. And I'm going to encourage you to pull out that adductor magnus. And what you're going to see is you're going to see these tiny little holes on the medial aspect of adductor magnus. And those little holes are where all the femoral profunda muscular branches come through. So you're going to see all these little, they're almost like pinholes. Completely separate from the adductor hiatus. Okay? Any other questions? Everybody good? All right, let's go ahead. Let's cut it there for today, okay? So Wednesday, we're going to cover the thigh. So just be prepared for that. And then obviously Wednesday after lecture, we're going to do the exam, but I'll give you details on when we're going to start and everything. Yeah. Oh, yeah. Absolutely. Absolutely.
Dr. Conley, when you were saying like everything affects each other, is that why like I happen to know like the actions and like the muscles and like just like man, there's 9 muscles going down the whole chain that do external rotation. Yep. So it's like basically saying whatever affects for like Gino Valgo would also.
Not necessarily.
Okay.
Not necessarily.
Depends.
Yep. It's not that cut and dry.
Okay. But the ones that are up top, so like external rotators, now if I want to stretch one, I would for hip external rotators, I want to internally rotate, but do I have to like bend the leg in order to? I was wondering if it's kind of the same concept when we were talking about stretching piriformis.
Piriformis is a weird one. You have to think about your attachments. Think about all those attachments for, especially insertions of the 60 lateral rotators.
Just need to look at their pictures.
Yep.
Just need to look at their pictures. And understand that femoral really is Profunda really is deep. So we have femoral and then deep all that musculature.
Yeah.
Profunda.
Oh, yeah.
And once you kind of think, wait a second, that makes sense.
Yeah. Well, and that's the thing, and that's where cadaver dissection is important, in my opinion. You know, I was just telling a group earlier that
It takes theoretically.
right. Right. That's exactly right.
Plastic sketch.
And that's the thing, you know, can we achieve the same or similar result with different media?
Right.
And that's where I'm at.
Because we literally could build this vascular system easy enough.
Yep.
Come up here, put this triple thick piece of yarn on here.
Information.
Femoral, this double thick piece of yarn on here.
Yep.
This single thick piece of yarn on here are medial and lateral circumflex.
You good, Rob? All right, no worries, no worries.
Tag those with just a little piece of tape. With the name.
Well, so